All right, everyone. Let's jump into a world we don't often get to see,
Oh,
the pathology lab.
right.
And specifically, we're going deep into the prostate gland today.
Sounds good.
And not just in like the textbook sense.
Mm-hmm.
We've got a real treat today.
Okay.
We've got audio from an actual prostate dissection.
Wow.
A chat between some lab pros, swapping stories and tips, and even snippets from a pathology lecture.
That's quite the combo.
Talk about an insider's view, right?
It really is a very unique combination of sources.
Yeah.
For sure.
So,
We're not just going to understand prostate conditions today.
right.
We're going to experience how pathologists approach them, the things you don't get from a textbook. You
It's
know?
exactly like, who knew prostate chips could be so controversial?
Oh, yeah.
We're starting with the TURP specimen, by the way,
Right.
for those who haven't encountered one before,
Mm.
transurethral resection of the prostate.
Yeah.
But it's those chips, these little uniform pieces of tissue
Right.
that really throw some people off.
They did.
I was reading in the lab chat some pretty hilarious comparisons going on there.
Oh, yeah. The snack food analogies are always a classic.
Yeah.
But beyond the initial, what is this reaction?
Right.
TURP specimens bring up a key challenge.
Okay.
These chips are strips from along the prostatic urethra. So getting a complete picture of the prostate is tough.
Which makes you wonder, why is TURP still so common if it's so limited?
That's a good question.
I mean, what are the patient implications here?
Well, TURP is generally less invasive and has a shorter recovery time than other procedures, like a radical prostatectomy.
Okay.
So it's often used for men with less severe symptoms or who are not good candidates for more extensive surgery.
Makes sense.
But the limitations are real.
Yeah.
The College of American Pathologists, or TKP, has a protocol to treat and make the most of these specimens,
Okay.
submitting the first 12 grams in terto
Okay.
and then 1 cassette per 5 grams after that.
Okay. So trying to get as much info as possible. But I notice in the chat that some labs go even further, especially for younger patients,
Yeah.
even if the specimen is small.
Yeah, there's definitely variation in practice.
Yeah.
Some will submit the whole thing if the patient is under 60, for example.
Wow.
They're thinking about the long-term risks.
Right.
Lower-grade tumors in younger men might become a bigger problem down the line.
Right.
So it's worth the extra effort to be absolutely sure.
It's almost like those tiny chips make the stakes higher for the pathologist.
Oh, for sure.
Every subtle color change, every texture variation could be a clue.
And that's precisely why you hear the pathologist in our audio sound a bit weary of TURPs.
Yeah.
It's that constant search for the hidden or occult carcinoma.
Right.
Finding it is one thing, but accurately quantifying it in those fragmented pieces.
Right.
That's a real art.
I bet.
Yeah,
So TURP is valuable information, but a
Yeah.
lot of pressure on the pathologist.
absolutely.
Now let's switch gears to a procedure where you get the whole picture, literally
Okay.
the radical prostatectomy. Yeah?
Whole gland, seminal vesicles, valve deafens the works. And in our audio, we get to be a fly on the wall as the pathologist walks us through the anatomy.
And it's not just any prostate, it's a 34-gram specimen.
Whoa.
Talk about a whopper.
Yeah.
When you think a normal prostate's about the size of a walnut,
Right.
20 grams or so,
Yeah.
this one raises some questions.
Right. What leads to that kind of growth?
Exactly.
Was it BPH or something else?
Right.
A real mystery.
Yeah.
But before we get to the cutting, let's break down this walnut analogy.
Okay.
You've got 4 zones to keep straight.
Mm-hmm.
Central, peripheral, transitional, and periurethral.
And those zones aren't just for anatomy quizzes.
Right.
They matter for what kind of conditions develop where.
Yeah.
Benign prostatic hyperplasia, or BPH,
Yeah.
usually hangs out in the central and transitional zones.
Okay.
Prostate cancer, on the other hand, tends to pop up in the peripheral zone,
Okay.
which, by the way, is why a digital rectal exam can be so effective for detecting cancer.
That peripheral zone is right there at the back, close to the rectum.
Makes you appreciate those exams a little more, right? So our pathologist has got this big prostate.
Yep.
And before they start slicing, what's the first order of business?
Weighing it, of course.
Course.
Not just for documentation, but also to figure out how much tissue processing they're dealing with.
Right.
And then comes inking.
Oh.
Different colored inks applied to different parts of the prostate.
Oh.
It's like creating a color-coded map to
Yeah.
guide them through the slicing and analysis.
And I was reading in that lab chat, some labs use 2 colors, some use 3, some even 4. It's like everyone has got their own personal style.
It's a mix of science and artistry, for sure.
Oh, yeah.
Speaking of artistry, get ready for the slicing.
All right.
It's amazing how they managed to cut this round gland into those precise 3 to 5 millimeter thick transverse sections.
It's delicate work keeping everything oriented properly, right?
It is.
Why is that orientation so important?
Think of it like a 3D jigsaw puzzle.
Okay.
If you lose track of where each piece came from, you'll never get the full picture.
Right.
And in this case, that picture is crucial for staging the cancer,
Right.
figuring out how far it spread,
Okay.
and ultimately deciding on the best treatment.
So as the pathologist is slicing, what are they looking for? Can they actually see the tumor with the naked eye?
They're looking for anything out of the ordinary.
Okay.
A change in color,
Right.
a firm area compared to the spongy, normal prostate tissue.
Okay.
But here's the catch.
Yeah.
Prostate tumors can be incredibly subtle.
Yeah.
They often blend in with the surrounding tissue, making them really hard to spot just by looking.
So it's like finding a needle in a haystack,
Exactly.
but a haystack that needs to be sliced perfectly.
Exactly.
Wow.
And even with all that careful slicing and scrutiny,
Yeah.
the final diagnosis hinges on the microscope.
Okay.
That's where they'll really see what's going on at a cellular level.
So let's say they've got the prostate all sliced up, inked, ready to go. How do they actually analyze those sections?
Well, some labs divide each slice into quadrants.
Okay.
Anterior right, anterior left, posterior right, and posterior left.
Okay.
And submit each one separately.
Okay.
It's all about maintaining that precise orientation.
Right.
Other labs go posterior first from apex to base,
Okay.
and then sample the anterior sections as needed.
So different approaches, but the goal is always to get a thorough, accurate representation of the whole gland.
Precisely.
Okay.
And then you have the margins,
Okay.
the edges of the tissue that we're touching surrounding organs during surgery.
Okay.
These are crucial because if cancer cells are hanging out at the margin,
Yeah.
it could mean the tumor wasn't completely removed.
So that's where those radial versus perpendicular cuts come into play.
You got it. That debate we saw in the chat?
Yep. The College of American Pathologists recommends perpendicular sections
Okay.
because they give you a more comprehensive assessment of the margin.
Okay.
It's all about getting the most information possible.
Leaving no stone unturned, so to speak.
Speaking of stones, did you hear about the pathologist finding actual stones in the prostate?
Oh, yeah. Those calcifications can be a surprise. It's like a little bonus challenge for the pathologist.
Oh.
Not only do they have to find the tumor,
Right.
they've got to deal with these little rocks that can dull their microtome blades.
Oh, no. Imagine.
Talk about a hidden hazard of the job.
Right.
It's amazing what you learn from these insider perspectives.
Absolutely. It's a good reminder that even in a field as technical as pathology, there's always an element of the unexpected.
Yeah. All right. We've covered a lot of ground here.
We have.
From the mysteries of TURP chips to the meticulous art of prostate dissection. We've even gotten a glimpse into the real-life challenges and unexpected discoveries that pathologists face every day.
That's right.
What's next on our deep dive agenda?
Now that we've got a handle on the procedures and the anatomy,
Right.
it's time to delve into the conditions themselves.
From the benign to the malignant, we're going to explore the diseases that affect the prostate and how pathologists play a crucial role in diagnosing and staging them.
Sounds fascinating. Let's take a closer look at those conditions right after this.
Welcome back to our deep dive into prostate pathology.
Yeah.
Before we get into the specifics of different conditions,
Okay.
I think it's worth highlighting what we've already learned about those different prostate zones.
Okay.
They're not just anatomical trivia. You know?
Right. They tell a story about what's going on in the gland.
Exactly.
And like you said earlier, where a condition develops can make a big difference.
Exactly. Take benign prostatic hyperplasia, or BPH.
Right.
It loves to hang out in those central and transitional zones.
Okay.
And think about what those zones surround.
Okay.
The urethra.
Right.
So as the prostate gets bigger, guess what gets squeezed?
The urethra.
Yeah.
Which explains why BPH often leads to those classic urinary symptoms.
Exactly.
Difficulty starting a weak stream, all those fun things.
Exactly. But here's the thing. BPH is super common. Yeah. Especially as men age.
Right.
We're talking nearly 90% of men over 80 will have some degree of BPH.
Wow.
But it's not cancerous.
Which is good news, obviously.
Yes.
But if it's so common and it's not cancer, why all the fuss?
Right.
I mean, when does it actually become a problem that needs treatment?
Well, think about quality of life.
Okay.
If you're getting up 5 times a night to pee,
Oh, yeah.
or you're constantly worried about accidents,
Right.
that's going to have a real impact.
Right.
And there are effective treatments, from lifestyle changes and medications to procedures like the TURP we discussed earlier.
Right. The TURP with its controversial chips.
Yes.
Speaking of things that can cause problems, let's talk about the big one.
Okay.
Prostate cancer.
Yeah,
I know it's the most common cancer in men,
it is.
and it tends to arise in that peripheral zone,
Right.
making it easier to catch with a digital exam.
Right.
But what happens after the pathologist sees it under the microscope? How do they figure out what they're dealing with?
That's where Gleason grading and TNM staging come in.
Okay.
Think of them as the dynamic duo of prostate cancer diagnosis.
Okay.
Gleason tells you how aggressive the cancer is,
Okay.
while TNM maps out its territory, how far it's spread.
Okay, I've heard the term Gleason score thrown around, but to be honest, it's always sounded a bit like a mystery to me.
It's simpler than it sounds.
Okay.
Basically, pathologists look at the cancer cells under a microscope
Mm.
and give them a grade from 1 to 5 based on how abnormal they look.
Okay.
1 is the least aggressive, 5 is the most aggressive, kind of like a cell behaving badly scale.
So the higher the grade, the more trouble you're in.
Exactly. But it's not just one grade. They actually assign 2.
Okay.
1 for the most common pattern they see and 1 for the second most common.
Oh,
Then they add those 2 numbers together to get the total Gleason score, which can range from 2 to 10.
so a Gleason score of 10 would be the worst case scenario.
You got it. But here's where things get interesting. We've learned that just looking at the total score isn't always the most helpful.
Right.
So now we group those scores into what are called grade groups from 1 to 5.
Okay.
These grade groups better reflect the prognosis, how the cancer is likely to behave,
Okay.
and guide treatment decisions.
So it's less about the individual numbers and more about the bigger picture of what those numbers tell us.
Exactly. Gleason gives us the personality of the cancer, if you will.
Right.
Now, TNM staging is all about location, location, location.
Okay.
The T tells you about the tumor itself, how big it is, and if it's poked outside the prostate.
Okay.
N is for lymph nodes, and M is for metastasis, meaning if it's spread to other parts of the body.
So TNM is like drawing a map of where the cancer is and where it's been.
Exactly. And in our audio, the pathologist mentions this particular prostate cancer is likely a PT2.
Okay.
The P means it's the pathologic stage, meaning what they see under the microscope.
Right.
T2 means the cancer is still within the prostate, hasn't busted out of the capsule yet.
That sounds relatively good, right?
Mm.
Like it's contained.
It's definitely better than cancer that is spread.
Right.
But the final staging will also depend on those lymph nodes and if there's any distant metastasis.
Right.
It's all part of the puzzle.
A puzzle with some pretty high stakes.
Yeah.
It makes you realize how much rides on the pathologist's analysis.
It does.
It's not just numbers and letters. It's about real people and their lives.
Absolutely. And that's why the details matter so much.
Yeah.
That's why they spend hours meticulously analyzing these tiny pieces of tissue,
Right.
looking for every clue that can help understand the disease and guide treatment.
Speaking of details, remember that lab chat we talked about?
Oh, yeah.
They were discussing some pretty interesting stuff.
Oh, yeah. The chat was a gold mine.
Yeah.
It really brought home how much is happening behind the scenes in a pathology lab.
Right.
Not just the science, but the practical challenges,
Right.
the innovations, even the humor.
I'm dying to hear about those mega cassettes.
Okay.
Imagine a slide that big.
It's what?
It must be wild seeing an entire prostate section all at once.
Yeah.
What were the lab pros saying about them?
Well, they were definitely debating the pros and cons.
Right.
On the one hand, seeing the whole picture can be incredibly valuable,
Right.
especially as we move towards more comprehensive sampling.
Yeah.
But those mega cassettes require special handling,
Right.
special equipment.
Yeah.
One person even mentioned needing a sledge microtome to cut those giant blocks of tissue.
Really?
Sounds intense.
It does, and it makes you wonder, what are the implications for IHC with those whole mounts?
Yeah.
I mean, can you really do IHC on something that big?
Good question. And that's exactly the kind of thing they were discussing in the chat.
Right.
Someone mentioned using a checkerboard pattern for IHC staining,
Wow.
where they only stain specific areas of the section to conserve antibodies
Okay.
and make the analysis more manageable.
Clever. It sounds like they're constantly coming up with creative solutions to these unique challenges.
Right. And that ingenuity extends beyond the mega cassettes.
Yeah.
They were talking about everything from labeling systems
Right.
to those pesky prostate stones that can wreak havoc on their microtomes.
Yeah,
It's a reminder that pathology is a hands-on field.
totally. And it's not just about the technical stuff, is it?
Right.
There was a real sense of community in that chat.
There was.
People sharing tips,
Yeah.
troubleshooting problems, even cracking jokes.
Right.
It must be nice to have that support system, especially in a field that can be so demanding and detail-oriented.
Absolutely.
Right.
They're all in the trenches together, so to speak.
Yeah.
And at the end of the day, it's that shared commitment to patient care that shines through.
Right.
They may not always see the patients face to face, but they know their work is making a difference.
It's a reminder that behind every diagnosis, every treatment decision, there's a whole team of dedicated professionals working tirelessly behind the scenes.
Yeah.
And that includes those unsung heroes in the pathology lab.
Well said. And speaking of unsung heroes, I think it's time we shift our focus to the everyday realities of lab life. Those little details that most people never see or think about, but that are essential to making the whole system work.
Let's pull back the curtain and take a look at what really goes on in the pathology lab. I'm ready for more insider stories. All right, you mentioned lab life, and I have to admit, I'm picturing those perfectly organized slides, the pristine microscopes, but the chat made it sound a lot more, well, lively than that.
Oh, it's definitely not all sterile silence and textbook perfection.
Right.
These folks are dealing with a constant flow of specimens, intricate procedures, and the occasional surprise or two. It's a lot more dynamic than people might imagine.
It's dynamic and maybe a little chaotic.
Maybe a little.
I mean, just thinking about the sheer volume of samples they process, thousands of tiny tissue pieces. How do they keep it all straight?
That's what impressed me, too.
Yeah.
They're masters of organization.
Yeah.
Think color-coded labels, detailed logs, a system for everything.
Right.
In that chat, someone was even joking about needing a spreadsheet just to keep track of their spreadsheets.
Oh my gosh, I bet. And those mega cassettes we talked about,
Yeah, no.
fitting one of those into a standard tissue processor must be like trying to stuff a watermelon into a lunchbox.
I know, right?
Like, how does that even work?
But they've got tricks up their sleeves. Someone mentioned these special mega cassette holders,
Okay.
almost like an expansion pack for the processor.
Wow. Who knew there was such a thing?
Right.
Like they're constantly problem solving or MacGyvering their way through the day?
And remember those prostate stones?
Yes.
Turns out they're not just a curiosity, they're a real hazard of the job.
Right.
Someone was lamenting about a particularly nasty stone that practically destroyed their microtome blade.
Oh my gosh.
Imagine trying to get those perfect paper-thin sections with a dull blade.
Ouch. It's like, even at the microscopic level, there's this element of danger. You know,
Yeah.
you're battling calcifications, trying to coax these delicate sections from stubborn tissue.
Definitely. But what really came through in that chat was the camaraderie,
Yeah.
the sense of humor. They're sharing tips, commiserating over frustrating specimens, and even cracking jokes about mega cassette Tetris in the processor.
That's great. They've got this secret society bound together by the shared experience of working in this hidden world.
And I think the shared experience is crucial.
Yeah.
Pathology can be demanding, isolating at times, but knowing you're not alone, that there's a whole community out there who gets it, that makes a big difference.
Absolutely. And at the end of the day, they're not just dealing with slides and machines.
Yeah.
They're contributing to real people's lives. Every diagnosis, every report they generate has an impact.
That's what I took away from this whole deep dive.
Yeah.
It's easy to get lost in the technical details, but behind it all are the patients, the doctors relying on this information, the team effort to understand and treat these conditions.
It really highlights the human element of pathology, doesn't it?
It does.
It's not just about cells and stains. It's about using that knowledge to make a real difference in the world.
Exactly. And maybe this deep dive will inspire someone out there to join the ranks of these dedicated professionals.
Yeah.
It's a field that's constantly evolving, pushing the boundaries of what we know about disease.
I hope so. It's been an incredible journey from those mysterious prostate chips to the surprisingly lively world of the lab. And who knows, maybe we've even sparked a little more appreciation for the vital role pathologists play in healthcare.
To all our listeners, keep exploring, keep asking questions, and never underestimate the power of a good deep dive. Who knows what hidden worlds we'll uncover next?